Hello and welcome, everyone. So great to have you all here today for our first live streamed MTI Live of 2025. This is a very exciting one because we're going to be hearing all about payers and all the different facets of working with them and optimizing your reimbursement as you bring your medtech innovation to market. So if you don't know me yet, my name is Nicole Black. I am the program director here at MedTech Innovator. We are the world's largest accelerator for life science startups. If you're joining from online, we bring each year somewhere between 60 and 70 companies through our US cohort accelerator program. And we have almost 800 alumni now that have gone through it. And so as part of our series during the summer, we will bring experts in to talk about topics that our cohort has expressed interest in to make sure that it's timely and relevant for them as well. And so when we did our survey of our current 64 cohort companies, we found out the number one thing that they wanted to learn about was payers, so both public and private. So super excited to be joined by expert panelists here today and how to put this payer puzzle together because as we know, this shouldn't require surgical precision to do so. So we're going to talk about how med device startups can navigate payer engagement, reimbursement strategies, evidence generation, and much more. And we're going to look forward into new trends toward coverage in the future. So without further ado, I'll start to introduce our expert panelists. And for each of them, I would love to hear 2 to 3 minutes about their background and types of payers that they've worked with throughout their very exciting careers. So we'll start off with Jessica Lamb, who's a senior consultant at Kaiser Permanente. Jessica.
So yes, I've been at Kaiser Permanente since about 2009. So it's been a while, and during my time there, I've done evidence. So evidence-based medicine is basically the sort of unit that I work with. Okay? So am I still on here? Okay. So I just got a message. Okay, I got a weird message from Zoom that keeps telling me it's quitting. Okay. Um, so yeah, so evidence-based medicine work. So I've been evaluating a lot of evidence for new technologies, medical technology. I used to manage our medical technology management process for Southern California. And before that, I used to do sort of health economic and outcomes research consulting for like pharmaceutical companies. So that's been my experience, and I'm happy to be here today to talk about Kaiser's and sort of system and how we evaluate medical technologies.
Awesome. Thanks, Jessica. We're looking forward to hearing your expertise. Next up, we've got Lee Fleischer, who's the founder at Rubrum Advising and the former CMS Chief Medical Officer and Director.
Yeah, Nicole, it's a pleasure to be here and have enjoyed actually being a judge at an MTI event in Dublin. So enjoy working with many in your cohort. So I'm a practicing anesthesiologist, although only twice a month, and the former chair of anesthesia at the University of Pennsylvania and a health services researcher. So when I was at Penn, I also had the privilege of being the lead physician negotiator for our contracts with payers. So got to see it from that side, trying to work with our local Blue Cross as well as some of the national payers. And also had the privilege of being on the Blue Cross Blue Shield Technology Evaluation Center's medical advisory panel. So got to work with a number of us who provided input into how Blue Cross Blue Shield evaluated technologies. Then, as you mentioned, I took in 2020 this role as Chief Medical Officer and Director of the Center for Clinical Standard and Quality at CMS. Among the various functions I performed, I reported directly to the administrator and did it both in the first Trump administration and Biden administrations. I oversaw the 18 facility types, so hospitals, nursing homes, etc. But I also oversaw the coverage decisions and helped work with the payment rules. So things like the Alzheimer's drugs, as well as colorectal screening, were some of the things I got to decide while there, and now have this advising firm, but also do a lot of policy work in Washington, including with the National Academy around technology assessment.
Thanks, Lee, and excited to learn more about these different hats later, especially Blue Cross Blue Shield and how you guys evaluate new tech there. So that should be for our cohort. And then last but not least, we've got William Jones, who is the President and Chief Medical Officer at CHI St. Vincent Infirmary. Love to hear more from you, William.
Thank you very much. My background is I practiced cardiothoracic surgery for 30 years before moving into an administrative role as chief medical officer and subsequently president of a 600-bed multi-specialty, primarily tertiary referral center in Little Rock, Arkansas. In addition, I have served both in the evaluation, strategic advisory board, and now board of directors of Health Tech Arkansas, which is a medical technology innovator and startup engine promoting new companies as they enter into the med tech world. And then work closely now with the Arkansas Hospital Association and the Arkansas State Legislature and the governor's office as we work through issues of healthcare delivery and healthcare reimbursement, both on the government to Medicaid level and then through the Department of Insurance, working with the various commercial insurers in the state on rate and premium assignments, and with looking at how particularly commercial insurers approve and adopt new technologies as payable procedures.
Awesome. Well, quite the diverse backgrounds between the three of you. So I'm sure you guys are going to have some great insight. And for those of you guys listening, if you have a question and you're on LinkedIn, please post it somewhere in the comments of the event, and we will try to get to that near the end. If you're part of our MedTech Innovator cohort, you guys will have an option at the bottom of your Zoom with a Q&A box. You can put questions in there. And after the first live streamed hour is done, we are going to get to additional questions that you guys have. So definitely pay close attention, and if something piques your interest, be sure to write that down, and we'll tackle those at the end. So we'll kick things off, bounce it back to you, William. So curious, what are the types of payers that medtech startups should consider, both in the US and EU? And what are the major differences between these types of payers, especially in how they're valuing new technologies?
Well, we lump payers into basically four different groups, and there's nothing magic about this. This is really from a functional point of view. There are governmental payers that are basically state funded, and that's primarily Medicaid, and the various types of Medicaid replacements that each individual state sponsors and offers. There is traditional Medicare, which basically is the benchmark against which all other payers are judged, in which in many cases their rates are determined. There's Medicare replacement plans, which are private insurance replacements for Medicare eligible recipients. And then finally, a commercial group, and that represents all the Blue Cross Blue Shields, the United Healthcare's, Aetna, Cigna, a host of others. What's challenging for medtech innovators is that each of these different four groups will reimburse different amounts for the exact same procedure, the exact same piece of technology, the exact same pharmaceutical, and it will be reimbursed by each of the groups at different rates within a state, and will also vary from state to a state. And this is true for all four groups. Medicare reimbursement in America is not the same across all states, even across all counties within a state. So I think as technology innovators are thinking about how they find a place for themselves in the market, really it's important to understand how technology and new procedures and new devices are evaluated first by CMS, and then as they move along for approval for payment. And it really is crucial that this be taken into account early in the process as you're beginning to think about bringing a technology to market. Because the truth of the matter is that failure to get approval for payment from anyone and all of these groups is really going to have a significant impact on the adoption of that technology and the ability of facilities to adopt that technology in the market.
Thanks, William. Yeah, super comprehensive. And I hope that was helpful for everyone to kind of get a lay of the land of who we're thinking about when we talk about these different groups of payers. I want to bring it back quickly to Lee to talk about, your experience at Blue Cross Blue Shield and how did they think about innovation and coverage for new medical technologies?
Yeah, it's interesting, and I don't know if you're going to talk later about CMS, but Blue Cross Blue Shield and the private payers are focused not only on reasonable and necessary, which is a CMS term, but also on cost effectiveness. So they're going to look at some of the different costs. They're going to look at the long-term effects. They're also going to look at what's the effect on outcomes several years from now, but not decade from now, because a lot of the commercial insurers have a time that's just a couple of years long. The interesting thing about Blue Cross Blue Shield and some particular is many of their plans actually administer the self insurance market. They really take many of these large companies. I'm in Philadelphia. You look at the Comcasts of the world, where they are administering their plan, and therefore some of the things that particular company cares about influences what they cover and how they think about it. So there's both the formal medtech evaluation with cost effectiveness incorporated, as well as the influence of how the corporate structure, the corporate world thinks about some of the benefits they want to provide.
That's great. And how would you compare and contrast this to CMS in this case?
So I know nobody believes this, but I can assure you that CMS does not take cost into account. Now, whether or not cost influences whether they'll do a national coverage decision or a local coverage decision, national being done when I was at CMS by the national group, or local being done by one of the 13 MACs. That, whether they take it on, can be influenced by how big a spend, how expensive it is. Once that's done, the question is simple: does it have clinical utility? As opposed to medical necessity, which is really what the Blue Cross question is. And that is it reasonable and necessary for the diagnosis or treatment of an illness or injury in the Medicare population? They can't do screening unless the USPSTF has spoken. So that's another thing which other plans may do or not do. And Medicare is a defined benefit, which means, for example, they can't do hearing aids because Congress said they're not allowed to. Well, the biggest thing is that then Medicare Advantage, so the privatization of Medicare, must do at least as well as CMS. We hope that's true, but they must actually anchor. So if you have a national coverage decision, MA must do that, but they can do more, but they can't do less. So a lot of your innovators like to have CMS say, yes, we'll cover it, either in a local or national, because that influences the Medicare Advantage plans, and they can't make a claim by claim decision.
Oh, super helpful. Lay of the land. I really like the, clinical utility versus medical necessity, and what the difference between those actually is, and how you might prove it's one versus the other, or both, hopefully, as well. So, want to also hear from Jessica. So, Jessica, how do payer models like Kaiser Permanente's integrated delivery networks differ from traditional fee-for-service models when it comes to evaluating these new technologies?
Yes, so we also don't really do a cost effectiveness analysis. I mean, we will, kind of look at the cost of a new technology and sort of kind of, I don't know, back of back of the envelope calculations, but not like a formal cost effectiveness. So we are very much interested, in quality and very much in efficacy and safety. So first, that there's not harms. Because Kaiser is an integrated delivery system, we're looking more at prevention, and most of our customers or patients are from like employer-based, type of model. So we have probably less or fewer people from the individual insurance market, versus the employer-based market, and therefore, actually, like our first year having a patient is often actually most costly. So our sort of efficiency is maintaining patients over time and keeping them within the system. And again, all of our physicians, all of our pharmacists, everyone is salaried. So it's not, fee for service where you're looking for throughput, you're looking for higher volumes and so on. So, because we're not contracting with any medical groups in that way. So our model is really set up to be more focused on actual clinical outcomes, and so that's really is what we are mostly evaluating, and looking for those kind of benefits to to improving care, without causing any additional harms. So that's really the metrics that we look at the most when we're evaluating new technologies, and it can be hard because a lot of times, there isn't enough evidence. I would say most of the time, looking at new technologies, we're kind of in a, looking at lower quality or lower certainty evidence. And so I think being able to at least make a case that this is improving certain efficiencies, or sometimes it might be a benefit to the physicians more than it is for the patients, but that can be valuable. So there are kind of different ways I think that you can frame sort of value that might, if it's not always a strong case based on the evidence alone.
Ah, and we'll talk more about evidence later too. I'd love to hear from you guys, like what in your opinion is valuable evidence to be showing to these different types of payers, and really speaks to the power of this preventative model. Jessica, that you mentioned, the first year is the most costly. After that, they've got their prevention and hopefully in better health. So that's really promising that the system is considering the long term, not just immediate care of the patient. Lee, you've worked with some of these integrated delivery networks in the past, from working with companies and helping to navigate, these different structures. How do you think a company could help navigate the structure? Do you have any advice on this?
I mean, Jessica probably could tell them how to approach her, but it's interesting when we're talking to a lot of companies and they're trying to figure out how to develop that evidence, because if you don't have evidence, you're not going to get coverage by Medicare and many of the other insurers. In particular, a lot of these things, because of the way we structure our bundled payments, some of the things are inside of what we pay one bundled price for. And people ask me, well, shouldn't we be paid for every app that comes out that helps every physician? And I say, as a taxpayer, you're already giving the physician a certain amount of money. If it improves things downstream, and that's what the integrated network can do, they can look and see who gets the benefit. And I think, that's really what they can do better than many places, especially because of our 510(k) pathway for a lot of med tech.
Mm-hmm.
A lot of people, and we think it's a mistake, many of us, and particularly in my firm, to come to market with no clinical evidence. I think it's critical that they think about the clinical evidence, they think about the payer, and one of the best places to get it is going into a Kaiser Permanente. We use that example all the time. And now it's part of Resent, so they can also look at Geisinger and a few others of those IDNs and say, we'll make you a deal. we'll give you a value-based contract or something like that, and then get the evidence to prove it's worthwhile that they can use with other payers.
Yeah, really good point. And glad you brought up, the 510K pathway. And for those of you listening, I assume most of you in the medtech space know what a 510K is, but this is basically a pathway for class 2 devices where you have a predicate device out there that is substantially equivalent to yours. So basically same or similar indications for use, type of product and usage. And so for a lot of these, since they're already have been considered safe by their, equivalent, they don't have to have a clinical trial to bring it to market. But yeah, as Lee alluded to, you often need that data for adoption and for coverage as well. So thinking in advance about that. In our MedTech innovator companies that are in our value program, we'll think a lot about, what is this evidence they need to generate? Just a benchtop study, animal study isn't going to be enough to convince a payer to cover this, isn't going to be enough for even a patient to go through with this procedure at a large scale. So how do you get that first data to move forward? So we'll be excited to see how our company's value propositions evolve during that program. Now I want to bring it back to William. So William, as a hospital system leader, so what are the key financial considerations you have when evaluating whether to adopt a new medical technology?
If it is a technology that's directly related to patient care and we're looking for reimbursement, I think Lee touched on this, and it's really important to understand that much of the way that hospitals are reimbursed is bundled. It's in diagnostic related groups. And so for example, someone with gallstones, that we treat them for an acute gallbladder attack, and we remove the gallbladder. We are paid by Medicare and most other commercial rates for the entire treatment of that illness, that entire hospital stay, with a single payment. And that payment is the same regardless of the method we use to remove the gallbladder, for example. So I think it's important as technology developers to understand if your product is going to be influenced by that. And that's going to be important for the healthcare delivery system, that you may have a great product that you think adds significantly to the patient experience or to patient care or to outcomes. But if that technology costs considerably more than the current technology in use, our reimbursement is not going to change. And so helping us understand the value of your technology, of your product that you're bringing to us, has to be, if it doesn't bring in additional dollars in reimbursement, then how does it improve? What does it improve? How does it bring value to the healthcare that we deliver? It's easiest if you have a technology that you can get approval and you've got specific funding for that. But I think many of the things that people are doing now, the apps, for example, that help us improve the efficiency of our care, there will not be additional dollars that are provided to us to pay for that app. So you got to come to market prepared to show what the value of that improved efficiency or for that improved experience for the patient is, in order for us to be able to understand how and why we should integrate that into our systems.
Yeah, really good point. And I think later too, we should talk a bit about, how does one go about calculating the monetary value of improved efficiency with some of these technologies? Easy to say it saves an hour, but what does that mean if there's multiple, staff involved, surgeons, anesthesiologists, things like that, and you could open it up to others. So I'm glad you brought that up, William. Awesome. So Lee, so based on your experience advising clients, what are some common mistakes or misconceptions you see medtech startups have when it comes to navigating the payer landscape?
Yeah, I think the biggest thing is understanding what the level of evidence and what defines evidence. And, for CMS, and I think for a lot of the payers, that's actually published, peer-reviewed published evidence. Certainly it was that way for Blue Cross Blue Shield, and it's definitely in statute or in regulation, certainly, that it has to be published. So very important. showing clinical superiority, and William sort of mentioned if you can bring extra payment, but CMS requires for any kind of add-on payments either breakthrough status or clinical superiority, where they really show it's better than something else. Um, you know, I also think it's important to understand, and I think William talked a lot about this, is who's going to buy it at the end? Is it going to be bought in the hospital and it's has no additional payment? Is it going to be bought in the physician's office? So almost understanding the clinical journey and working backwards to see what you need, because that for us, we're not sure they all understand that you need to figure out, is the buyer the insurer, the physician, the health system, the integrated health system? I think that makes a difference in how you approach what evidence you need and how you demonstrate that evidence going
Yeah.
forward.
Yeah. Hopefully helpful to the startups out there. And also, Jessica, I'd love to hear from you on this. Some common mistakes or misconceptions you see when people approach you for working with Kaiser Permanente.
Yes. Well, first, I just wanted to echo what Lee said about, having peer review published evidence. That's definitely what we are also looking at. I mean, we really kind of, and we don't do systematic literature reviews by definition, but we definitely, our approach when we're evaluating evidence is, from that sort of literature review methodology. So we are, even if they're supposedly higher quality studies, I mean, we are really looking very closely at the studies. We pick them apart. We're doing a synthesis of all of the literature. So we are looking very critically at the evidence. And sometimes, having a randomized controlled trial it's not a slam dunk. There's a lot of low quality RCTs out there. Um, so definitely that evidence piece is very important. And if you can demonstrate, yes, superiority either over, kind of what the standard of care is currently, or compared to, some other, competitors in that space, then that is very, more compelling. Um, Quite often, I would say, you don't always you usually don't see a lot of comparative studies comparing versus, one technology to another technology, although that's something that I think that's the question that we'd all like answered quite frequently. Um, as far as, at Kaiser, what else? Like oh yes, things that we don't, or that we'd like to see, or sort of the mistakes, I guess, that you were talking about. I mean, I think not having, really not understanding sort of the specific sort of patient population that you're looking for. So sometimes, you're trying to get the 510, you're trying to do that pathway, and then you kind of go for, just a broad population. But really, we need a very more focused populations. When we're looking at evidence, it's going to be it's got to be a very focused sort of at what we call PICO methodology. And so that having a really understanding the population in which something's going to be used, how it's going to affect the clinical workflow, those are really large concerns, because when we bring in experts too, from whatever specialty it is, when we have our sort of committee review, it's really going to matter, especially if you are shifting care from one specialty to another, or from, one level of care to another. All of those things really impact the workflow, and that's also going to be of a big concern in whether we decide to adopt something. So think those kind of concerns, and then also really thinking about the data and how the data is going to be used. For Kaiser, we're very proprietary about our data. So if it is a technology in which it's going to be using our data, then there's got to be a lot of thought put into that too, and how our data is going to be protected.
That's great. So have data and have it make sure it can be protected because they're going to do a deep dive. So great advice, Jessica. Awesome. So one last question before we move into talking about some different strategies toward reimbursement. Lee, bring this one to you. So what is the most efficient way to engage and onboard payers, including CMS and private insurers, for coverage conversations?
CMS will take meetings, and we also are able to get meetings with a lot of the payers, even the MACs. What's interesting, and this gets to one of the mistakes I think some medtech groups make, is they say, we have a code. We're just going to start billing it. And then, CMS has made a big deal about fraud, waste, and abuse. It's like every, speech that Mehmet Oz gives, he talks about it. They have great AI now. They can detect at much lower levels, all of a sudden someone's starting to use something that they shouldn't have approved. Because usually what happens is they pay if you have a code, and then they look at whether or not you have medical necessity, and then they claw it back. And that's really bad for a company. So in fact, the MACs, and I'm glad to see William shaking his head, the MACs have actually suggested come in and say, we don't want an LCD. We're not ready. We want claim by claim. Let us show you our data. Let us present you with a dossier. And a lot of groups do have dossiers created with our evidence. And you could tell us what we should have as criteria, because it's not everybody who deserves their technology, but there are groups that they hopefully have shown they benefit. And I think that's what the payers are looking for, is those discussions to say, we have good evidence. We'll try to make sure that we have good program integrity, that we're really using it in the right patient population. We're not just trying to get lots of people to use it tomorrow, because they'll find you.
Yeah.
Yeah.
Good that they're willing to have a conversation and maybe contribute what additional evidence they think you may need. William, did you want to add something onto this?
I did. I just want to emphasize something that Lee said. Encourage people, please do this the right way from the beginning. Is don't try and backdoor it by using an existing code and hoping that it's going to work. And that is more common than I think people realize. I mean, it is happening all the time, and it will catch up with you in the end. And 10, 20 years ago might have worked, but it will not work now. And it shouldn't work. It's not the right way to do things. Do it the right way from the beginning.
That's a great way to end the payer engagement session of this. Thank you so much, William. So, thinking forward as these startups are moving toward, reimbursement success, what are some first steps that they should make? Lee was talking about like having a conversation. What are some other steps they should take? William, you can take this one.
Oh, I'm sorry. I think that it's with whether it's medical technology or bringing any new product to market, you've got to really understand, how do you fit in? How do you fit in with the grand scheme of things? You may have a great idea. You may have the next best mousetrap. But if you've got the next best mousetrap, you got to know where the mice are. And make sure that you understand how it fits in. Have a compelling story that you can tell. And whether you're talking to Lee at CMS, for him, the compelling story is going to be what's the data to prove that this works and that's better than what we have. For Jessica, it's going to be how this fits in with your grand scheme of care of the total patients that you are taking care of. For me, it's all of those things, plus, quite frankly, can I afford it or not? So understand how you fit into the marketplace, what it is that you have to offer, and recognize that in each discussion, who is your audience, and really tailor your presentation, tailor for how you intend to market to what that audience is.
Love the know where the mice are for your better mousetrap. Lee, you want to add on to that?
Yeah, It's funny, when we were in the agency, we used to call things called murder boards. Hadn't heard of it before, but the legislative office would uh, pepper me with questions so that when I got in front of the hill, I would survive. But in some ways, you want the skeptics in the room. You don't want the founders of the company. You don't want all the KOLs that love your device. You actually want the KOLs who are skeptic. We frequently will take a company to a number of KOLs that I know that will key opinion leaders. I actually didn't know that term until I got into consulting, but those key opinion leaders, those clinical experts, and you see there are two clinicians here on this call, and to help us say, what will it take to convince you that it's the right thing for your patients? Which I know Jessica also strongly believes, but that clinical skeptic.
Yeah, would love to hear more from you, Jessica, too, and more about this clinical skeptic in the room, and also, why is it important for startups to have a focused clinical pathway and value proposition going into some of these meetings?
Yes, I mean, I think when we're adopting a new technology or considering that, I mean, we're always going to be thinking like, okay, which patients is this for, right? And which patients is it going to benefit? Um, there's many situations in which I think you know we sometimes get physicians that really want something, and so it can actually be hard because we look at the evidence and we're like, this is, and we're very objective about it, and but physicians often, when they are presented with the data, they will say, okay, we see, we we see what you're saying, but again, it's not necessarily it's not necessarily a closed door on something just because the evidence isn't great. But again, it's got to be a focused enough question. It's got to be very clear what patients are going to benefit. And so sometimes, even looking at the studies, you can kind of, it's like, well, this isn't great, but maybe there's certain ways that if our physicians want to use it, they want this product, that we can kind of narrow down that patient selection or put some things in place to make sure that we are going to at least have sort of higher quality. I mean, I think we want better outcomes, right? So if we can kind of narrow things down a bit, so it's always going to kind of get even more specific and more focused usually, especially when the evidence isn't great. So I think that's another reason why it's got to be focused enough, because if you're just taking, everybody, looking at everybody with diabetes, or I mean, you're probably not going to be able to show a lot of impact actually. So and that's usually why it ends up being very specified. But that also means that as a company, you maybe aren't making as much money, right? If you can't apply it to more patients. So I think it's a tough balancing act. And when you go from, okay, well, this is, the market that we're hoping to get, and then but like from a payer perspective, it's like, well, who is this really going to benefit? Because that's really what we're going to narrow down on and zero in on, is which patients is this really going to benefit.
If I
Really good perspective. Yeah, go Lee.
if I could just say something that Jessica said, that idea that don't try to get every patient, because it's a higher probability. We've had companies come to us and say, we could affect 120 DRGs for an add-on payment. I'm like, do you understand? CMS is going to say no. If you say we've got 5 that we're sure and a win, and then you can expand, particularly for things like add-on payments, because then you need William to buy it for his hospital for a small indication, and then let people work with it, and then it might grow. Much saner strategy.
Like that
Nicole,
approach. Yeah, go ahead,
Nicole, if
William.
I can just tell a quick story that I think
I
will be
love that.
helpful to people, that echoes something that Lee said about the clinical skeptic. And the importance of that as you're preparing to go to market. I have a daughter who's an attorney, and her practice is limited to taking medical biotechnology companies public, does the IPOs. And she's based in Washington, but she come home for a long weekend. Was actually working from our home one day, and I walked her through. She has her monitor set up and her headphones on, and whoever is on the other end of the Zoom call, she is yelling at them and she is just giving them a hard time. And I was kind of embarrassed about it. And after the call was over, I said, golly, it's really hard when you talk to your colleagues that way. And she said, no, Dad, that wasn't a colleague, that was a client. And they are getting ready to take a product and do a pitch. And they hired me to be as mean to them as I possibly could so that they would be best prepared. And I think that's an extreme example of what Lee was talking about. But I think that the point that for all of us is be prepared. Is get the people. Don't surround yourself only with the people that admire your technology and believe in it. Get the skeptics in the room so that when you go talk to Jessica or when you go talk to Lee, you're prepared. You're not going to be surprised, and you've got a better chance of not only impressing them but convincing them of the value of your product.
That is really great advice, William. And I love that story. Someone was paid to be a critic. And I think, for our startups that have such small teams, I love to emphasize this to them is, you don't just want yes men on your team. You want people that are going to challenge you, push you, question things, because this is going to make you stronger overall as a company. And when you get in these situations in front of the payers and value analysis committees, and you're asked all the hard questions, you'll be prepared for it. So really love that you brought that in, William. So I want to bring back to this reimbursement pathway and, how you might demonstrate that your tech is reasonable and necessary. So Lee, are there examples of companies that have not met this reasonable and necessary thresholds, and how can this be avoided?
Yeah, I think, the most interesting question about reasonable and necessary, and they've always wanted CMS to define it, and still hasn't fully defined it, but there's something called the MedCAC. The thing we tell companies is go find an outcome that CMS or the MACs have already paid for. A lot of companies make the mistake of, I do some work with brain computer interface companies, and they're asking, if we can walk faster, is that a good outcome? Well, CMS can't pay for walking faster. I'm not sure Kaiser's going to pay for walking faster. I'm not sure William, but preventing falls, absolutely. That's a great outcome. Being able to turn the channel on the TV, but activities of daily living where they can feed themselves. I like to tell a story. And the story is wheelchair seat elevation and standing elevation for quadriplegics. And I got to CMS, and Tabby Duckworth, who, the senator was like, I still remember being yelled at and being told, you've got to approve these. And I said, but Congress, you didn't tell us that there's a benefit category that we can pay for something that's a convenience. It actually says that it's a convenience. And I said, just help me. And ironically, my first cousin died of muscular dystrophy, and his parents died early from transferring them. Just be able to give me the data to show me that there's a medical benefit. And they finally were able to show that upper girdle strength for hemiplegics or for muscular dystrophy patients can be preserved by having this seat elevation for transfer. But they couldn't show it for the standing. And we were able to actually approve that. So that idea of what are the important outcomes that the insurer cares about, I think is critical for almost everything we've been talking about.
Oh, it's super, super helpful to hear. And that, you can have these other strategies around that to get coverage in these different scenarios. even for these more like optional type technologies. So want to talk a bit about like pass-through payment pathways as well while we're on here. So William, on our prep call that we had, you mentioned the importance of medtech startups being able to secure these pass-through payments from CMS or private payers rather than relying solely on the standard reimbursement. Can you explain why this temporary pathway period is so critical for the hospitals when adopting these new technologies, and what are the risks if the technology loses this status?
It can be very important because it can help technology companies get in the door, get started. And the benefits of that, I think, are twofold. One is that it can help the continuing accumulation of data that's supportive of the use of the device, perhaps even help learn about additional indications or additional uses for the technology. But the other is, and I would really encourage startups to look at these temporary pass-throughs in this way. It is a temporary payment by Medicaid and by Medicare and other payers that helps a new technology get established, but is intended to be temporary. And I think that the best use of that is to get out in the market so that you can be able to ramp up your production and take advantage of economies of scale as sales continue, so that then you're able to bring your technology back at a price that is consistent with what the market and what reimbursement will pay for it. So I would encourage people to pursue this, but once you get it, the work's just begun. That's just the beginning of it. You have to take advantage of that. I'll call it that benefit, that gift that you have been given as an opportunity to be able to establish yourself in the market, but it will not continue, and you can't make your financial plan based on it continuing. You've got to figure out how then you bring your cost and your pricing down to a level that's consistent with the reimbursement that you'll eventually receive.
Yeah, makes sense. So take advantage of that while you can. Yeah, Lee.
Yeah, Nicole, what William said. Now, sometimes the benefit is so great that they can show that they'll actually reprice the bundle, the DRG, they'll add it in. But you really got to show total cost of care makes a difference. Many of the developers had heard about the medical coverage of innovative technology. It was put out in 2020. I was there when we pulled it down in 2021. And one of the problems was what happens at the end of the 4 years where you got this automatic coverage. And that's why a lot of people are saying it's, William, you said it perfectly. Create the evidence during those 3 years, because a lot of companies will do this and then
Yep.
I've seen them crash at the end of
Absolutely.
the 3 years.
Great. And building our coverage from there. So Lee, would love to hear from you, the importance of startups securing a positive local coverage decision from a Medicare administrative contractor. And what are some risks if a technology doesn't have this, and some strategies they could use working toward it?
Well, I think I started earlier and said the claim by claim and going in and saying that when they don't have you don't want a non-coverage decision. That's the worst thing that can happen. So you don't want to go in and ask, and that's what can happen if they see you expanding wildly without sufficient evidence. They'll actually say no, as opposed to staying in claim by claim until you have that. So, but if you have enough, it also gives you an opportunity, particularly if you have for one of the 13 max or one of really the 2 max for the DME, essentially 2 max, to get that experience presenting, trying to develop a good balance, and as you get more evidence. But it can take up to a year to get a local coverage decision.
That's a long period. So hopefully, yeah, have in the meantime those pass-throughs and pathways to get some coverage in the beginning. I want to move into evidence generation a bit and alternative coverage models in the last 10 minutes here. And reminder, if you guys are listening and on LinkedIn and you have a question for some of our fantastic panelists, please post it. So hopefully I can get to that in the last few minutes before we turn it over to our MedTech Innovator cohort for questions. So in talking about evidence generation, Jessica, you've been a really strong supporter of our value program while, and so I've seen different value creation strategies, evidence strategies, generation strategies from these startups, mostly focused on clinical trial plans. So do you always need a randomized controlled trial for payment decisions and other types of evidence that can be compelling for companies to work on? Yeah.
So I don't think you always need to have a randomized controlled trial. I mean, I think it depends on, what your device does, and what what the clinical context is. Certainly, I mean, you have preference for randomized controlled trials unless it's like a diagnostic test, and in that case, you would probably want like a high quality cross-sectional study. But for I would say what kind of other evidence? I mean, I think it really depends on the clinical context. So if this is like a disease with a high burden of suffering, there's not really any other good alternative treatments. You probably don't necessarily need a randomized controlled trial unless there's maybe a huge safety concern. But even then, I mean, usually like an observational trial. I mean, if it's like a rare disease, it might be hard to do a randomized controlled trial. So they're definitely different contexts, and we don't always, it's not always about an RCT. Certainly, if you are addressing certain gaps in care, that's also a situation where we just, it might also be hard to do an RCT as well. So, but again, it's just you've got to be really thoughtful and really understand your clinical context. So, definitely understand how something would be used and the full workflow. I think that's something that I have to keep stressing, because I think a lot of times looking at some of these early startups, they just haven't really done enough kind of homework yet into understanding the full context, how something's going to be used from beginning to end, and how it might change, the current pathway, and who are all the players and stakeholders that's going to affect. So I think that those are some real considerations. And again, just going to bring up the whole data thing. How is the data going to be used? Because we're seeing so many technologies that are maybe incorporating like machine learning algorithms and things like that. So these are all concerns, and definitely, we have, dedicated, departments now that are very much like classify things based on the data use. So that's going to affect how something might be adopted or not adopted. Yeah, I mean, in terms of trying to get a pilot done, I mean, it's not easy, and you definitely need to have some, I think, at least some evidence, like at least, from, at least a good case series or some, single center generated evidence, at least something you have got to show some proof of concept before you are trying to sort of say, hey, let's work together.
Yeah, thanks, Jessica. Super helpful. So, we talked about value clearly for the patient and some of these clinical trials, but William, also coming back to your statement at the beginning about, improved efficacy being one value driver for hospitals to adopt a new technology. What are some best practices for demonstrating value beyond the patient, such as reducing these downstream treatment costs, improving efficiency, population level impact, things like that?
One of the challenges for healthcare delivery organizations is we have to be good stewards of our resources. We're limited not only by levels of reimbursement, we're limited by availability of appropriately trained and skilled staff. We're limited by time, hours in the day, and other resources. And so I think that additional ways of demonstrating value beyond just reimbursement payments would be directed towards improving efficiency. We just implemented a new technology in our electrophysiology labs that is at least as effective as previous technology that we had used, but cuts the time for performing the procedure by about 40%. And it also improves the safety profile of the procedure. That is a big win-win for us, because now not only can we provide care that's just as effective as the old method, but it's safer and it takes a shorter period of time. And if we're wise, we use that additional time to be able to treat more patients. And so I think that that really represents a great opportunity for these innovators. Think not only about how this can be paid for, but how you can use this to improve the efficiency of how your hospital or your care for delivery system works, so that you have the ability to care for more patients, or provide that care more for us safely. You know, we tell our folks, people that we onboard here, number one job for us is keep people safe. Number one job, and we can never forget that. So anything that will make that care safer will always add value, even if we can't show it in dollars and cents.
Great that you mentioned that, and bringing this back to Jessica, who was talking about preventative medicine. So would love to hear from you, Jessica. Looking forward to some future trends, like what are some of the key pay points or inefficiencies that you see in the current healthcare system that these innovative technologies could help address?
Yeah, I mean, that's what William was saying is very, very true. We're definitely very focused right now on the ambulatory care environment, and we're very focused on trying to prevent errors and mistakes, which seems like basic, but I think there's a lot of things in place in the in-hospital setting and the inpatient setting, but less so in that and sort of that outpatient setting. So that's something that's a big focus right now, and it's so the safety component is huge. And so any technologies I think that can help reduce those kind of errors, and especially in that ambulatory care setting, is very big for us. I mean, we obviously are, we've been looking at things kind of using existing data. So recently, I reviewed like CT-based opportunistic screening for osteoporosis. So look, using existing scans that we already have from like abdominal CTs that have been done, and so on, to look for osteoporosis. So things like that, which are, it's kind of, we already have the data. So can we use the technology to just evaluate something that we already have, rather than having people trying to get more people in for DEXA scans? So these are kind of, looking for efficiencies as well. And I think that those are the kinds of things that are going to be especially more attractive to any really hospitals or any delivery system right now, because there are a lot of constraints financially, a lot of uncertainty in the market. And yeah, when we have sort of fewer doctors to do things now. So
Oh, great. And optimistic that you see this as such a pivotal part of our future healthcare pathway. Awesome. Well, we've got some questions from LinkedIn, so maybe we'll tackle those now first. So in medtech innovation, we often highlight the value of reducing secondary interventions through improved outcomes, which ultimately lowers the total cost of care, something payers and integrated systems value. But many providers generate revenue from these secondary procedures. How do you reconcile this tension between payer cost savings and potential provider revenue loss? What strategies or incentive miles have you seen that work to align these interests? So Jessica, sounds like a great question for you.
well, I mean, again, I don't think we're not as much focused, I guess, on driving up more services and having secondary interventions. So I think, for us, that's not really a goal, is to have more interventions. So I don't know that that's really a big concern. But I think we're really just trying to really just reduce like having to have repeat procedures. I mean, we don't really, we want to reduce revisions and those kinds of procedures. So that's our goal is to not have unnecessary procedures like that. So.
Great answer. William, what about for you guys?
Yeah, I would tell the people, whoever asked this question and anybody that's listening, is that a healthcare delivery organization that is planning a strategy based on secondary interventions and follow-up interventions, and basically the medical equivalent of designed obsolescence, is not long for this world. It is simply not. And I think what just a basic tenet of business that we practice that I think will serve them well is why are we here? Why are we here? We're here for the patient. And as long as we put the best interests of the patient at the center of every decision that we make, we will make the right decisions.
Right. Maybe we need more of these integrated health systems to really benefit that long-term value and not see that conflict arise. So, Lee, if you want to tackle talking about Medicare coverage of innovation technology program under the current administration, and what have you been hearing about alternative pathways to this?
And William's statement, both, and Jessica's, are so true. And if you listen to the administration, they're moving to mandatory models. Thankfully, for those of us who believe in value-based care. So that means this idea that really are looking at total cost of care. So aligning both the patient and the financing. Medicare wants to get to more innovative technology. We've heard very clearly that, for those who understand about MCIT, that MCIT's not coming back, but they do want to enhance sort of accelerated TSET, for those who understand, for breakthrough technologies, the transitional coverage of innovative technologies. The last thing I did before I left the administration was help put out those policies. And the idea of try to get innovation earlier. And that's, if you look at it, it's really about getting your evidence earlier. The nice thing about, the question is a few things. They're going to try to create models that allow the clinicians, the hospitals, the end users to decide what will help them get to better health. Because as we all know, that's the secretary's focus, is better health, not treatment of disease. So a lot of these wearables, they will figure out mechanisms to fund them, but within models. So you have to decide. The Kaisers, William, the St. Vincent Infirmary will have to decide what to give you to get you there. Not they'll have a code and they'll get paid for. So you're really convincing the end user. The other thing I think that's going to be important is that they're going to try to fund many of these, how to accelerate the development, and if you have evidence, how to get it approved quicker to get payment, and making sure that the payers, the Max and I think Medicare Advantage, pays you appropriately, and not through all the prior authorizations that's occurring right now for denials, and therefore making coverage criteria effectively used for all Medicare beneficiaries, for those, whether it's fee for service or MA.
Thanks, Lee. Hopefully that is helpful to you guys listening. And one final CMS related question, actually, from the LinkedIn audience before we turn over to our cohort Q&A. So any secrets regarding moving from CMS coverage decision to Medicare Advantage plans to commercial payers?
Yeah, we're actually working with AvaMed on some of this, around making sure that the MA plans really follow the coverage decisions. So it's important, and there are a number of groups to say, to speak up when you see this discord. But that's why having evidence to get to an LCD or a national coverage decision is really critical, because that's the only way to help hold the Medicare Advantage plans feet to the fire. Otherwise, if it's claim by claim, which is what Medicare does for most technologies, they're essentially, you're stuck with Medicare Advantage being able to do whatever they feel is appropriate.
Great. Well, thank you so much, Lee, for that insight. And thank you, Jessica and William, as well, for answering these questions during our public panel portion. Thank you all to everyone. Just before you guys head off, we will have our next live streamed MTI Live on August 14th. So it'll be Deal or No Deal, reading between the terms. So all about term sheets and negotiating the terms in those. Hope to see you on that one. But round of applause. Thank you, Lee, Jessica, and William, for your wisdom. And hope to see those of you on LinkedIn Live soon. MedTech Innovator cohort, please stay on for the private Q&A session. Again, you can continue to put questions in the chat box. Thank you all and see you soon.